Hello, everyone. My name is Gabriel Altit. I'm a neonatologist based at the Montreal Children's Hospital. And today I'll be speaking for the NeoFOCUS Collaborative of the UK. It's really an honor and pleasure, and I'll be talking about phenotyping acute pulmonary hypertension and prematurity. So these are my disclosures. I do want to mention that a lot of the content of this current presentation is based on my own experience and interpretation of the literature, and that many of the medication discussed have not been tested in the context of randomized controlled trial, especially in the context of premature newborns, unfortunately. And another thing is that Mallinckrodt supported the NeoCardio Lab through an unrestricted educational grant in terms of the website. So the objectives today will be to define what acute pulmonary hypertension means in the premature infants. We'll talk about how different phenotypes may be corresponding to acute pulmonary hypertension, and so how important it will be to decipher between these phenotypes when we assess babies at the bedside. And we'll talk a bit on the available literature on the current acute PH management in premature infants. I want to bring us back to this wonderful representation from Dr. Gabriel on fetal cardiac physiology. We know that during fetal life, we have high pulmonary vascular resistance and low systemic vascular resistance due to the fact that we're connected to the low placental resistance. Except if we see that, there's obviously increased stiffness into the vasculature due to conditions like preeclampsia, maternal hypertension, which can eventually impact the SVR, increase this SVR, and eventually have also profound impact on the fetus, both from a growth perspective, but also from diminishing the right to left shunt at the PD level, which may force a bit more output into the pulmonary vasculature and remodel the pulmonary vasculature in these patients. And we also know that, because they face higher SVR during fetal life, some of these patients are at lifelong risk of a systemic hypertension cardiovascular condition. Now, coming back to the normal fetus, I find the fetal physiology quite fascinating and how it's all well orchestrated to change as the fetus grows. And I want to remind ourselves how preterm infants are basically coming out of this process quite early, which can definitely impact both their cardiovascular function, cardiac growth, pulmonary vascular growth, and systemic vascular growth. And so it's important to remind ourselves that these babies are vulnerable, immature, and that a lot of the mechanisms that are in place in the term infant are probably not yet mature in the preterm infant. And so when we're choosing therapies, we do have to remember that both on a mechanistic level and embryological level, these babies are quite different than term infants or even pediatric patients. Now, we know that in fetal life, we have fetal shunts, one of them being the ductus arteriosus. And I do want to point out a very important concept that hopefully you will keep upon yourself for the rest of your life, but at least for the rest of this presentation, is that if you see here, the pressure in the pulmonary artery is 70/45, and the pressure in the aorta is 70/45. So it's very important to disconnect the concepts of what is pressure, what is flow, and what is resistance. And so in fetal life, we're connected to a very low placental vascular resistance circuit. And we're, facing very high pulmonary vascular resistance. But because this duct is wide open, it is basically a channel that will equalize pressure. And it's the directionality of this duct that indicates the relationship between the vascular resistances in both compartments. And as you can see, the pressure are being equalized. And so the systolic pulmonary arterial pressure is the same as the systolic blood pressure in the fetus, which is the same for the diastolic. And this remains true unless this duct starts constricting, becoming restrictive, and so not allowing this pressure equalization to occur, and so forcing potentially flow to be going towards the pulmonary vasculature. And so we see that in premature closure of the ductus, where there's this premature either restriction or closure, which sends too much blood flow to the pulmonary vasculature, leading to pulmonary vascular remodeling. But it also creates a situation where the LE preload increases, which diminishes the right to left inter-atrial shunt and forces more blood flow into the RV cavity. So it's a bit of this vicious cycle that happens in fetal life and leads to RV remodeling and eventually poor RV compliance, because it becomes very muscular. And in the postnatal life, it takes time for this right ventricle to actually remodel. The other thing of importance is that inter-atrial shunt during fetal life are right to left typically, unless there's a shift in compliance of the underlying ventricle. And the second key concept I want to bring about is that inter-atrial shunting is dependent on the underlying ventricular compliance. So whatever this atrium is connected in terms of ventricle, the shunting at the atrial level will be dependent on the compliance of these ventricles, and that's true for also the postnatal life. So after birth, as we know, we get eventually closure of some of these shunts. But one of the things that happens that is very abrupt is that we do end up disconnecting the placenta, which will increase dramatically the systemic vascular resistance. As the lungs are being exposed to the oxygen and to the extrauterine life, there's mechanical stretch that happens. There's obviously these alveoli that will expand and stretch the pulmonary vessels that are within these alveoli, which includes arteries, capillaries, veins, and lymphatics. And so this whole cascade will lead to a drop in pulmonary vascular resistance, increase in pulmonary blood flow, increased left atrial filling, increased left ventricular filling. And because at the beginning of this process, the PD is still open and the PVR are dropping relative to the SVR, which have shoot up quite significantly, there's slightly a higher QPQS through this duct, increasing a bit the pulmonary blood flow, leading to a bit of a higher LA filling pressure, which eventually will revert the shunt at the level of the foraminal valley and create this flap closure at the level of the interatrial shunt, which remains open in about 25% of the population. I think everyone in this room or in this audience is probably an expert at this fetal transition to extrauterine life. Now, what's important is to understand that a lot of these mechanisms that are occurring are studied within the fetal lamb. And we assume that a lot of these mechanisms are quite similar within the newborn, at least term newborn population. But when we start speaking about patients being born preterm, and especially now, babies born at the level of almost the intersection between canalicular and saccular stage, of course, first of all, these mechanisms are not necessarily as matured, whether it is at the level of cell surface or intracellular mechanisms. But there's also a lot of unknowns related to the fact that there's immaturity in the pulmonary compartments, in the pulmonary veins, pulmonary arteries, pulmonary capillaries, the capacity of the heart to adapt to these changing loading conditions, and also to this whole process of SVR and PVR changes, because we know that the vascular network within the systemic vasculature is very different. We also know that, the delivery brings about a whole load of different cytokines, or at least I should say biomarkers like endothelin, adrenal hormones, and preemies are potentially lacking some reserves in these adrenal hormones, like endogenous epi and norepi and cortisol and this whole fleet of different stress hormones that term babies had time to build up in terms of maturity before delivery, which preterm may not have, and so they may exhaust very quickly their reserve, and may not be able to respond the same way than term newborns to added stress. And so I want us to keep this in mind when we start thinking about therapies and the effect of these therapies, but also about the fact that potentially some of these mechanisms, like production of endogenous nitric oxide, prostacyclin, et cetera, may not be similar to what we see in the term infant. And so when I first think about acute pulmonary hypertension, at least in term babies, but even in preterm babies, I think about transitional issues. I think about the fact that these transitional issues are leading in the failure of these mechanisms to drop the pulmonary vascular resistance to whatever is the expected or normal for these babies. And so to allow the pulmonary blood flow to increase and to allow the systemic compartment being filled by this pulmonary venous return, and eventually contributing to the systemic output with oxygenated blood flow coming back from the lungs. And so whenever you get a failure of this mechanism, I consider that, you need to start figuring out, well, what's happening to my baby that's causing my baby to have poor perfusion, poor oxygen delivery, and eventually tissue ischemia, which can lead to damage or even mortality. Now, I think if we would ask many people what acute PH means, we would get many definitions because we know that this transition in the postnatal life still takes time. So there's not clear-cut numbers of either vascular resistances or the pressure that translates resulting from these vascular resistances that will tell us within this transitional period, oh, this is abnormal or normal. And that's what we're going to try to decipher together. So what are potential disturbers of PVR? Well, of course, hypothermia, infection, lung disease, having low pH, high PCO2, but also other things that we may not think about, like stress, seizure, some of the medications that we start. Ibuprofen is a potent pulmonary vaso and systemic vascular constrictor that stays around the body quite for a long time. Pain, inflammatory changes, the fact that they had exposure to malperfusion, for example, or pH buildup, lactate buildup in their tissues, even in fetal life can be also disturbers of PVR. So all of these things are also potential targets to think about when we start treating these patients. Of course, if the baby's hypothermic and preterm, we need to normalize temperature. Of course, if the lung disease is full blown, no matter how much, I know you're going to be starting, you're probably not going to be able to achieve adequate pulmonary vascular resistance drop if you don't have adequate recruitment and adequate ventilation to perfusion matching. Because if all your alveoli are collapsed, the INO will never get there, of course. And of course, if you have an infection, either it is bacterial, viral, Candida, or other types of, more unconventional infections like malaria, you need to think about how you're going to best treat this setup, which may lead to the perinatal distress and a huge burden of condition of disease in our premature infants, or of course, for those who are coming out to be unstable and with these phenotypes are, of course, from, maternal fetal infection and chorio and some of these elements that will increase the inflammatory burden. So let's go back to the drawing board and talk about acute pulmonary hypertension, try to figure out what's our definition. Because if we look to hyperintention, it means high blood pressure in the pulmonary artery. But I'm not 100% convinced that this is what we mean every time we speak about some of the babies that we see that are very blue in our unit with right ventricular dysfunction, et cetera. And we'll talk about some of these phenotypes. I do want us to remind ourselves that pressure is often a function of flow and resistance, plus the distal pressure. So in the context of the pulmonary vasculature, we often think about the left atrial pressure, which is the draining pressure. And that left atrial pressure will be, affected by many things. But if we go back to flow and resistance, you can talk about hypertension or high pressure in your pulmonary vasculature because your resistance is very high and the flow is being maintained because RV is able to maintain that flow, or you have a duct to maintain that flow. So what do we think here? Well, of course, that phenotype of severe PPHN or acute PH due to high pulmonary vascular resistances. So these vascular resistances that are very, very tight. And because of that, the pressure will start to rise. So that would be one condition of that. You can have suprasystemic pressures because you have very high flow, but on top of that, you have high resistance. So we often see that in lesions like hepatic AVMs or vein of Galen malformation. You can have very high pressure because you have like torrential flow, but your resistance are actually either, not so high or normal or even dropping to accommodate this flow. And so which is typically rare, but we could see in preemies if they have abnormal autoregulation. But typically the lungs will react by slightly increasing the resistance when it senses increased QPQS. So, if you have a large left or right PDA or a large VSD, you're not going to be suprasystemic. You're actually going to be isosystemic, but you're going to have very high flow and the pressure will rise in your pulmonary artery to the systemic level. You can have situations where you have very high pressure because you have distal obstruction. So you can think of LA hypertension, LV dysfunction, LV hypertrophy, that's very severe, severe MR, mitral stenosis, total anomalous pulmonary venous return that are obstructing or critically obstructing, pulmonary vein stenosis, pulmonary veno-occlusive disease, which is a very condition of the newborn associated with almost near 100% mortality. So these are situations where you have what we used to call post-capillary pulmonary hypertension. And so these patients will actually present with like whiteouts of the lung and pleural effusions. And it's really not a thing, it's really not an issue of actually too tight resistance that you need to give pulmonary vasodilators in some of these florid conditions. Then you have situations where you start dropping your flow in the presence of high resistance. So think about a situation where you don't have a PDA to pop off the afterload from the right ventricle, and suddenly your RV is failing and it's just not able to eject flow anymore. Everything is backing up into the system, either in your liver, which is going to become big, or into your right atrium that is able to pop off in the left atrium if the inter-atrial shunt is big enough. Your baby will be very blue everywhere, but there's just not a lot of flow. And if you put an echo probe, you're going to see that your patient doesn't have that much high TR in terms of RV pressures because it's just not able to generate any forward flow or limited forward flow. So we talk here about failing right ventricles, very dilated right ventricles, and decreased pulmonary blood flow, such as, for example, if you have a restrictive duct that is right to left or bidirectional. Then you can have situation where your RV is so failed that it's almost dead and there's just no RV output. We talk about situations like functional pulmonary valve atresia or Epstein anomalies, where they can have this physiology where the resistance are so high and the RV is not able to mount any flow into the pulmonary vasculature, that actually you may even have a left to right PDA in these patients, but you have torrential right to left shunt at the atrial level because of this physiology. And these babies are very blue. And if they're not blue, it means they don't have torrential blood flow at their interatrial level because it's either too small or there's no shunt at the atrial level. And at that point, these patients become very gray before going to a low cardiac output to the point that they're going into cardiac arrest because there's just no filling into the left atrium, into the left ventricle in these patients. So I want us to remind ourselves that pulmonary vascular resistance will also be impacted by what's happening at the level of the lung interface and parenchymal interface. So of course, if you have very collapsed lung, your pulmonary vascular resistance will start to shoot up because there's just no ambient oxygen and all these vessels are being crunched down by the collapsed lungs. On the contrary, if you have a mean airway pressure of 28 on high frequency oscillation, you will be squishing these vessels, artery, veins, and capillaries, and that will shoot up the pulmonary vascular resistance as well. So you have to keep that in mind when you're managing your patient and you keep on increasing your mean airway pressure on the baby who's hypoxic. So we spoke about other things to consider that could be stressors or contributors like hypocapnia, hypocapnia, that will decrease PVR, but hypercarbia that will increase PVR, situations like metabolic acidosis, hypothermia, issues with hematocrit in some of these patients. And if you have like sympathetic stimulation, vasoconstrictors can also be things to think about when you're looking at some of these patients. So then again, now that we realize that acute PH can fit different phenotypes, I think we often think about the high PVR phenotypes. And I think that's what's better to call these patients is what's my physiology and what am I trying to target? I think if we have a patient that is becoming blue and we get more physiological information and we see this patient has RV dysfunction with high PVR, that's what the management strategy should be targeting. If this patient has a restrictive duct that is left or right with an RV that is not functioning, well, we should provide an entropy to this RV. We should try to, promote the forward flow via the duct because at that point, this is ductal dependent circulation. And so maybe this duct needs to be reopened. So the strategy needs to be about more what is the actual physiology than trying to, actually keep one recipe for all of these patients. At least that's what's my conviction about these patients. And so what I try to keep as a, nomenclature is that when I talk about acute PH or PPHN, it's really that really strict definition of I have PVRs that have not dropped yet and are too high and are leading to actually cardiovascular repercussions, because it's very expected in the first 24 to 48 hours that the process of dropping PVR is still undergoing. And so it's very common that we'll see some of these babies with a bit of bidirectional PFO, and PA pressures that are going to start to be, still a bit high if the duct has already closed. And so that's to be also kept in mind. So you can have very high PVR and flow is maintained. It means that your pressure will rise a lot. You can have PVR that are very high and flow is reduced, which means that the pressure could be within normal to expected age. And sometimes, as I mentioned, your flow could be so reduced that the pressure will actually be low with high PVR, like in functional pulmonary valve atresia. And so these patients will have very, very high PVR, but they don't have hypertension in the sense because they don't have high blood pressure. Their pressure is actually quite low because the flow has dropped so much. So bringing us back again to two other key physiological principles that I find when discussing with trainees gets them quite confused. It's bringing us back to that first visual from Abe Rudolph, where I told you that when you have a big channel that connects two vessels, the pressure will equalize on both sides. And so when you do have a big PDA, P1 V1 equals P2 V2, that's Boyle's law. And so pressure will be the same on both ends, and it will be the flow that will be leading to this pressure equalization. And so, for example, if you have a big duct and your SVR is very high, if you put a little catheter in your pulmonary artery, the pressure will be the same as the one as your aorta, but your QPQS will be very high and you're flooding your pulmonary aorta with too much flow. On the contrary, if your PVR are very high relative to your SVR, it's going to be the other thing. You're going to have a right to left shunting. Your two pressures will be the same. You'll be isosystemic by definition in your pulmonary artery, but the flow directionality will make it that the flow will go from the pulmonary artery to the aorta, and sometimes it's at the expense of flow into the pulmonary artery. So this time the QPQS will become much less than 1. The other thing to keep in mind is that increasing afterload is poorly tolerated often by the right ventricle. So afterload is a bit like bench pressing. It's trying to go to the gym and pushing this bar. If I take a little bar with no other, weights on the side, it will be very easy for me to bench press. But if I start adding 200, 300 pounds, eventually I'll start failing. And so that's the same concept about afterload. The duct being open, what it will do is that it will offload this afterload. It will basically expose the right ventricle to the combined outflow tract resistance. And similarly, the aorta facing a huge duct will also be exposed to this combined vascular resistance. And so that's very important to remember when you have a post-tricuspid or at least a ductal shunt or things like a truncus arteriosus or aortopulmonary window. So for example, this is a patient, very commonly I see people telling me, oh, there's a flat septum on the echo in systole, which means that the RV and the LV pressure are the same. That's absolutely true. When you have a flat septum, you can expect to have about isosystemic PA pressure, which means that if you don't have an outflow tract obstruction, your RV systolic pressure will be about your LV systolic pressure. That's what's telling you. Now you have to figure out, is this RV systolic pressure similar to the LV systolic pressure because I have a huge duct or a huge VSD that's equalizing pressure? And if so, the directionality of the shunt will then inform me on the relationship between SVR and PVR. Now, if the duct is closed, then I have to think, well, my systolic pulmonary arterial pressure is likely similar to my aortic pressure if I don't have outflow tract obstruction, or do I have a bit of pulmonary valve stenosis, which is increasing my RV pressure and is creating this picture of flat septum? Or could it be that I have low aortic blood flow or low aortic pressure because I have, for example, beginning of a sepsis or systemic vascular dilatation because of Graves' disease. So it's these things that you have to keep in mind when looking at the relationship between the RV and your LV. So that's just an example of a patient with a bit flattening of the septum, which was near-term corrected, preemie, with a huge duct, very left to right, relatively low velocity, non-restrictive, at least clearly on this TNE, with some TR outlining that the pressure were the same in terms of RV systolic pressure. So if you would just look at the TR and the septal curve, you would say, oh, this patient has pulmonary hypertension, maybe because of high PVR. But when you look at the ductal flow, you see that it's completely left to right. And by definition, the PVR are lower than the SVR. It doesn't tell you if the PVR underlying are low normal, or they might be high and just lower than your SVR. And so you have to wait for this ductal closure or bring these patients to the cath lab for better investigation to understand what's happening downstream in this pulmonary vasculature, because you're always going to have some degree of pulmonary vascular constriction in the context of increased QPQS as a modality to compensate for the increased QPQS. But the pressure read itself is just telling you that you're reading the pressure from the equalization of pressure across this ductus arteriosus. Now, when you start seeing bowing of the septum, this tells you that the RV systolic pressure is likely higher than the LV systolic pressure. That could be because this patient has transposition of great arteries, for example, but it could also be because your patient has such high right ventricular pressure that it exceeds the left ventricular pressure. For example, it could be because this is way too high compared to the LV that's high, but maybe the LV is also high. So maybe you have systemic hypertension and pulmonary hypertension in this patient. Maybe you have critical pulmonary valve stenosis in this patient. And so the LV pressure is normal, but the RV pressure is very high. Maybe you have a gram-negative sepsis and your LV pressure is near zero and you don't have a duct. And so at this point, the RV pressure is much higher than the LV pressure without being necessarily abnormally high. So it's all these things you have to keep in mind when you're looking at your patient and doing your comprehensive assessment. And finally, I do want to point out from the septal curve that when you have a nice round septum, this is a patient who had RV systolic pressure around 2/3 systemic. But because it was infrasystemic, this septum looks very round. It doesn't seem that there's any flattening. And so you can have, for example, high RV pressure, but LV hypertension. You can have a high RV pressure, but they're not yet iso or suprasystemic. And so it will give you this appearance of round left ventricle. So a few examples, this is a big left to right PDA. This patient will have, by definition, isosystemic PA pressure, but we know that this patient has very low PVR. And because it's a left to right shunt, this aorta is sending oxygenated blood to the pulmonary vasculature, which creates this vicious cycle of, furthering the pulmonary vasodilation and the low PVR state, which increases even more so the QPQS. Here you have two examples of bidirectional PDA. In this case, it is very large. It's unrestrictive. So you see it's bidirectional and tells you that in early systole, it's right to left. And for the rest of diastole, it's left to right. So you may have a brief moment of the cardiac cycle where the PVR are higher than the SVR, but ballpark, it's about isosystemic and the velocities are very low. So it tells you that there is nice pressure equalization across this duct. This is another patient that has, what looks to be a tiny duct with higher velocities. You have at least 2 meters per second. So if you apply Bernoulli, which is a bit of a duct never assumes all the assumptions of Bernoulli equation. But what we see is that the PA pressure at the peak of systole, so just after the QRS, is at least 30 millimeters of mercury above the aortic pressure, likely underestimated because the PDA is not a narrow point and it's actually more of a tube. But this tells you that, here you have both suprasystemic PVR and suprasystemic PA pressure. And then finally, this you see a right to left shunt at the ductal level where the PDA is becoming very small and restrictive, very high velocity, indicating that both the PA pressure and the PVR are much higher than what's happening in the systemic compartment. Comparatively, this patient has a large duct, which is unrestrictive, low velocity. Here you can tell that the PVR are much higher than the SVR. But if you look at the septal curve, it's going to be flat because you're creating a pressure equalization across this big duct, which connects the PA to the aorta. When we look at the inter-atrial shunt, as you remember, we mentioned that the inter-atrial shunt directionality depends on the compliance of the underlying ventricles. So here you have a full right to left, here full left to right, and here bidirectional. Very common to see bidirectional left to right in the first few days of life. You're not going to see this in a normal situation. So you have to start thinking about other diagnosis. And depending on the amount of volume that is shunted, it will have a more or less profound impact on the measurable saturations. So I've put here the differential diagnosis of a strict right to left inter-atrial shunt, which means that it's just completely right to left. The first thing you have to always rule out if you're the first one scanning this patient is always total anomalous pulmonary venous return, because it's an obligatory right to left inter-atrial shunt, because everything is coming back to the right atrium and nothing is coming back to the left atrium. And then you have these other things that you're going to be ruling out, like, for example, tricuspid atresia, PPHN, severe pulmonary hypertension, hypoplastic right heart syndromes, severe Epstein anomaly, and all these other diagnoses. And there's probably much more than that. So another key physiological principles to remember in acute PH, because that's often the first clinical manifestation we're going to be looking at, deoxygenated blood will enter the circulation if you have a shunt that is from the right to the left. And it's important to remember that, of course, if you have a normal cardiac configuration. And it's important to remember that because you may have a right to left shunt at the PDA level or atrial level, and it might not be because you have high pulmonary vascular resistances. So pre and post SAD differences, pre-ductal hypoxia, this may not be because you have high PVR. And we will try to see that in all the phenotypes. So that's just inter-atrial shunt, where if you have a right to left shunt at the atrial level, you're bringing blue blood into your left atrium. And so you will be more desaturated in the pre-ductal area. So if you're pre-ductally desaturated, it could be because you have this right to left shunt here. It could be you have a right to left shunt at the ventricular level, or it could be because you have VQ mismatch, or it could be that your duct is sending blue blood into the aorta and feeds retrograde into the pre-ductal aorta. And so that's very important to realize these different sources of pre-ductal desaturation. Similarly, post-ductal desaturation, when you have, especially in pre-post-ductal SAT differences, it's because you have a duct that is shunting from right to left. So you can see all this richness of phenotypes can really challenge research standardization. So we'll go back to some of the concepts we just outlined. This is the classic high PVR relative to SVR. Your PD is very large. And so these patients have a lot of right to left volume shunting at the level of the duct. So we'll have pre and post ductal saturation differences. Sometimes they can have VQ mismatch, or they can have right to left shunting at the atrial level, which make their left atrial oxygen level quite low. And so you may have, for example, pre-ductal sat around 80, post-ductal sat around 65. They look like this. This is a ductal view, right to left, very large, bidirectional, but mostly right to left at the atrial level, bringing deoxygenated blood in the pre-ductal compartment. This is an example because we're speaking about prematurity, a baby 24 weeks that was born in the context of choreo and had positive actual microbiological agent in the blood. And you can see here that there's a right to left shunt at the PDA level that is unrestrictive. You see here the Doppler. You can see here that because the duct is wide open, there's actually flattening of the septum. It's not a septum that's bowing into the LV cavity. There's right to left inter-atrial shunt. So you can see in the Doppler that it's nearly completely right to left, maybe a blip of left to right, but it looks more like artifactual. And the RV function is actually relatively preserved, part of which because there's TR, and so it's very easy to offload into your right atrium compared to bring blood flow forward. But this patient had a good RVO actually. And that's, the RV function is being maintained because this PD is offloading this right ventricle. Now, as you start to decrease this PDA, you're not able to offload the right ventricle. And also, you're not able to send that much RBCs that are hypoxic into the systemic circulation, which makes that these patients may have significant RV dysfunction, high RV and diastolic pressure, and shunting from right to left at the atrial level, making them quite desaturated. And so these patients eventually, if they lack pulmonary vascular flow, the problem is that they will underfill their LA, and they are dependent on this right to left shunt to maintain output from their left ventricle, because otherwise they're completely underfilled. So these are patients often with struggling RVs that are very dilated, they're suprasystemic. You can see that there's bowing septum. And in this particular case, there's a PDA that's right to left, but it's in systole, you can see that it's right to left and with a gradient of 33 millimeters of mercury. And this patient had about 50, 60 of systolic blood pressure. So it tells you, the math makes sense that this patient had high RV pressure, high PVR in systole, and an RV that's currently failing. So the way you're going to treat this patient might be a bit more different, because you may want to actually introduce also agents to support your RV function. And sometimes you may even need to reopen this duct if the RV output starts to become compromised. Then you have situations where your RV is so drastically affected that it's not able to pump any output. And so at this point, this is functional pulmonary valve atresia. You have torrential right to left shunt at the atrial level if you do have an inter-atrial shunt. Otherwise, this patient will become very gray quickly and eventually die from no output from the LV. They're dependent on a source of blood flow, either from the duct in the lungs. And if that starts to become restrictive, it can become quite a problem. Your baby will become quite blue. And so these patients can be very blue if the duct becomes quite restrictive. And so at this point, the LV pumps into the aorta and is sending blood flow in the pulmonary vasculature because the RV is just not able to generate forward flow. So that's an example of a patient who had severe RV hypertrophy and had a complete right to left shunt at the atrial level because the RV compliance was just extremely poor. And because the RV was not able to fill, this patient had barely any output in the RV outflow tract. And you can see here that the duct was very tiny and left to right. This patient was sitting in the 60%. And really not improving despite any other, oxygen therapy and all these things. And so what we ended up is increasing the ductal caliber with PGE in this preterm infant, because this was a preemie 25 weeks. And you can see here that the RV now is nicely filled and has a good function. And this patient immediately responded by, dropping the amount of right to left shunting at the atrial level, because you're filling more your LA and your LA pressure is going to rise. And so you're tempering a bit this right to left shunt at the atrial level, and this baby is then much less blue. So immediately this patient had a drop in their oxygenation need on the ventilator. This is a recent case. It's the case of the month on the NeoCardiolab website of September 2025. It's a 25-weeker who had ruptured at 18 weeks and had anhydromnias. What you can see here is the pulmonary valve with basically free PI, which it's mild to moderate. There is basically no forward flow from the RV. The RV is pumping almost everything retrograde via TR into the right atrium, and there is a significant right to left shunting at the atrial level. Here, this is the Doppler and the RV outflow tract, where you can see that there are almost no RV forward flow. And then this PDA was completely left to right. It was actually large. So in this particular patient, we did not initiate PGE because we felt the PDA was big enough and we were worried that we would maintain the duct open way too long. We introduced dobutamine to support RV function and forward flow, and we provided INO to decrease the PVR, to decrease RV afterload and promote RV forward flow. And we also dropped dramatically the mean airway pressure, and this patient actually recovered within 24 hours. I do want to mention that some of these patients don't have a duct, either because they're a bit older and then they end up living a stress like sepsis, or because there was a prenatal closure. So this is an example of actually a patient with significant right to left shunting at the atrial level because the RV is quite hypertrophied, and you can see that the duct is completely closed. And so these patients will not have pre and post ductal sat differences, but may be very profoundly desaturated everywhere. And then you have the mimickers. These patients who present with, a lot of pre and post ductal SAT differences. People get thrown INO on this because they don't have much more information physiologically. They may have normal preductal saturation because they have a lot of left to right shunt at the atrial level because the LV and diastolic pressure is quite high. But because the LV is not generating output, it's basically acting as a ductal dependent systemic circulation. So this is an example, severe LV dysfunction, a bit of RV dysfunction. You can see that this inter-atrial shunt is actually quite restrictive, high velocity, because the LA pressure starts rising, and PD is completely right to left. And so this patient presented with pre and post SAT differences. This is another example. This is the same where you see again the biventricular dysfunction. And we posted in March 2025 on the website another case of a preterm infant, 30 weeks, who had cardiac dysfunction, so severe LV dysfunction, a completely large right to left PDA. You can appreciate a bit of the septal flattening, I think, with the underfilled RV. And you can see here that your RV becomes a systemic pump. This is the interatrial velocities, and it's completely left to right. So this is a patient that was preductal desaturated, postductal desaturated. And the reason he was preductal desaturated is that there was so not forward flow, and you can see barely the aortic valve opening, that all the flow going into the ascending aorta was retrograde. And so you get blue blood from the PDA feeding your postductal, but also your preductal aorta. So this patient actually had this physiology where the PDA was feeding the descending aorta, but also the preductal aorta, mixing with the trickle amount coming out of the LV and giving this pre and postductal SAT differences, but also preductal desaturation. And I can go on with many, many, many more variations. Hopefully, you guys are in agreement now that acute PH and training can look in different shape and forms. And it's really this richness that allows to create research standardization. So what about the management and evidence? I wish I had the solution and tell you that we had multiple RCTs. If we look simply at the most common agent that we use to drop pulmonary vascular resistance when PVR that are too high is the main problem, and we look at preterm, a lot of these studies have looked at either chronic administration or administration in the idea to prevent mortality or BPD, and not necessarily to address phenotypes of high PVR. And what we see is that there's really no indication from all of these trials that INO improves survival in preterm infants. And that really, there's nothing about these studies that are showing that you're changing the outcomes of neonatal morbidities or IVH. Now, hypoxic rest failure is many things. You have RDS with parenchymal lung disease, cardiovascular phenotype, cardiorespiratory interaction, infectious sepsis, metabolic conditions. And so you have to keep in mind when looking at these older studies. At the CPS, the Canadian Pediatric Society, we did recommend that if you have a phenotype that is compatible with high PVR, INO can be considered as a rescue modality, especially if you have a situation that can be related to high PVR, like oligohydramnios and pulmonary hypoplasia. And that in extreme preterm infants, you may want to consider lower dose INO, because in some of these studies that have started 5 to 10 ppm, they've been drastic immediate responses. And because these patients with prematurity often have also a large PDA, you have to be very careful at reversing very rapidly the shunt. So, I would say we don't know what's the real true answer about whether or not INO changes the outcomes of these specific babies. But what we know is that these patients, from empirical evidence, respond to INO. And because there are other matters like vulnerability of their pulmonary vasculature, you want to avoid creating the perfect setup for a pulmonary hemorrhage. And so locally, we've chose to start INO at 10 ppm and then titrate based on that and use TNE to help us guide this management, or echo from our cardiologist. And so, but I still know some units that consider starting directly at 20 ppm. This is the result of the Pinot trial. 6 patients against 6 patients in placebo with PPROM, oligo, and pulmonary hypoplasia, and the mortality was dramatically different if exposed to INO in these contexts that are associated with pulmonary hypoplasia. And there was some improvement in oxygenation, but as you can see, a very tiny population. We looked back at the Canadian population of preterm infants less than 32 weeks, and what we found is that those patients presenting an early acute PH confirmed by echo, really translating high PVR, there was definitely a difference in the mortality rate in these patients compared to those that were not exposed to INO in these patients. And of course, there were some dramatic changes in oxygen support. We also have a group from Toronto that outlined their own population of preterm infants, mostly extreme preterm, and they found that responders to INO actually had lower mortality. So my answer is often like, if you think that INO is going to resolve the phenotype, just make sure that if you don't have a response, you're going to be titrating out and that you follow very closely your patient, especially if you're going to start having a reversal of the duct directionality, as well as if the patient doesn't have a pre and post ductal SAD differences, well, you shouldn't keep your patient on INO if on the echo your PD is mostly left to right at that point, because then you can create harm. The group of Dr. Gissinger, Dr. McNamara also published their own population of 22, 26 weekers, and they did find that, in these patients with acute PH, there was 2/3 that were responders on echo, and those actually had less mortality and grade 3 PPD. So we do have some evidence. It's mostly observational, but I do hope that we're going to have more RCTs to help us guide our management in these preterm infants. The problem is that it's increasingly being used, and that many units have voiced that they don't really have equipoise anymore when they have these setups of high PVR. I'll skip this. So how do I manage? Well, I think I look at the phenotype and try to provide some precision medicine. And until better evidence, I think physiology will help drive the care to a reasonable approach to tailored therapy. Now, remember that preterm infants are very immature infants and they may not respond exactly the same way. So always stop, take a moment, and instead of creating soup of different agents, make sure you reassess all of them and make sure you always go back to the drawing board and actually you tailor your therapy and avoid just accumulating polypharmacology in some of these babies. So I do like a lot this table from Dr. Gissinger, who had produced these different phenotypes that we outlined. So high PVR isolated versus if you have LV systolic dysfunction and RV, so biventricular dysfunction, versus if you have some degree of LV dysfunction that's more pronounced or RV dysfunction that's more pronounced, providing anotropy, considering PGE and some of these phenotypes are quite important. So how do I approach simply the patients with high PVR? I, of course, maximize my ventilation in terms of supporting, the recruitment, but not going overboard and eventually creating over-recruitment and high alveolar pressure. I try to avoid hypocapnia, of course. I do provide surfactant for RDS, and I consider sedation analgesia if I see that I have reactive component to the PVR with patients being manipulated and really decompensating during such manipulation. I try to titrate my oxygen to aim around 90 to 95%. And if I see my oxygen that I increase is not making a difference, I'm going to titrate down until I see it makes a difference. Of course, I consider INO in my population of patients where I've outlined a phenotype of high PVR. If I do see that there's concomitant ventricular dysfunction, I do consider inotropic support. I'm very careful in preterm infants with PGE, only in very selected cases. For example, in a restrictive PDA and my patient has functional pulmonary valvular atresia, then I would consider it. But most of the time, you don't need PGE in preterm infants, to be honest with you. That's more for the term baby. And then if you have a patient with preserved LV function and high PVR, and an RV function that is starting to struggle, you may want to consider other agents like vasopressin or norepi, which have been used in some of these setups. And always consider adrenal suppression as a potential contributor. So I'll skip this one, but I'll put this slide from Dr. Satyan, who's brilliantly outlined the effect of these different drugs based on systemic and vascular, pulmonary vascular constriction and dilation, as well as their effect on the different contractility or not. So we know norepinephrine has no effect on contractility versus epi and dopa does, but they both will have a tendency to increase your PVR. So these may be good choices in like sepsis with a huge left to right PDA, for example. Vasopressin may have a bit of an effect on pulmonary vasodilation and increase a bit your systemic vasoconstriction. So such example, when you have really low diastolic pressure because you have poor LV output from poor LV filling by the pulmonary vasculature, and you have, because of that, poor coronary perfusion, this may be a good agent to consider. Milrinone are really in situations where you have more of a chronic phase. Patients are peeing and you have good blood pressure and you're consider adding on a pulmonary vasodilator. It does have some inotropic effect as well. So I've put all the pulmonary vasodilators that are currently available on the market here, many of which have never been tested in preterm infants. But I do want to showcase that, inosildenafil work on the same pathway, and milrinone and prostacyclin PGE works typically on the same pathway as well. So in conclusion, preterm infants are at risk of disturbed transition. They may have issue where their PVR are not dropping sufficiently and creating this picture of hypoxic rest failure, especially if they have signs of pulmonary hypoplasia. But not all hypoxic rest failure are acute pulmonary hypertension. So terminology and phenotyping is quite important in order to eventually enhance the precision that we provide in terms of therapeutics, but also as we do research, even if it's observational, to kind of call an apple and a banana. And until more trial evidence, what we do have is, physiological and precision medicine based approaches. And so I do hope that we're able as a community to do more trials to better decipher what are the best agents to use and the dosages to use depending on the different clinical contexts and phenotypes. But I do think that isolating these phenotypes will help us get better in how we actually venture in some of these trials. So thank you very much for your attention. I'll remain available for comments or questions. My email and contact information is here.